Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we will be discussing cellulitis. Are you familiar with cellulitis, or are we starting to get a little bit?
Well, I'm familiar with cellulite. I don't think I'm familiar with cellulitis. I think it sounds like an infection.
Okay. Now,
itis usually sounds like an infection.
Itis would always be inflammation of something.
Caused by something.
I always say cellulitis is poorly named because cellulitis, you start to think it must be inflammation of the cells, and it doesn't make a lot of sense.
You have another name for this, perhaps?
No, unfortunately, we're stuck with cellulitis.
Okay.
But I will say what cellulitis is an infection of the subcutaneous tissues.
Okay.
And so it's not quite a superficial skin infection. It's not an infection on top of the skin, but it's actually an infection of the skin, of the subcutaneous tissues.
Got it.
And it is one of the most common reasons why I get called as a consultant.
Really?
Yeah, you would think this is common, it's straightforward, but as we're going to discuss today, it can get a little complicated.
Oh.
And one of the things I'm going to say is part of what makes it complicated is that there are two main types of cellulitis.
Okay.
And this is going to be interesting in some of our future or some of our other talks about skin infections or skin rashes or skin conditions, is in cellulitis, we break it down into a non-purulent and purulent. And the non-purulent is our classic erysipelas or streptococcal skin infection, which tends to be very superficial, very warm, very red, often with distinct margins, distinct borders. You can almost draw, well, you can take a pen and draw the margin, and as a person gets better, you can see the red tide of the infection recedes, versus a purulent, which is where the infection tends to enter through hair follicles, and there will be areas that may actually form abscesses and pockets of pus.
Goodness.
And so our erysipelas is almost all the time going to be streptococcal infections and very easy to treat with simple antibiotics, where our purulent, we start worrying about staph, and one of our problems with staph are growing resistance rates. So this becomes important for the clinician, for the provider, to distinguish between our non-purulent erysipelas cellulitis and our purulent, I'm worried maybe about staph cellulitis.
Sure. So the press is filled with news every time it happens of people acquiring flesh-eating bacteria.
Yes.
And is that falling into this category of a purulent cellulitis, or is it something even worse?
It's even deeper.
Fine.
No, but that's good. It's even deeper. And when you're seeing a patient with cellulitis and making the diagnosis, you want to be clinically distinguishing between cellulitis and a deeper infection.
Got it.
The flesh-eating bacteria that we sometimes hear about would be a necrotizing fasciitis. And this is often caused by strep species, where the strep will get between the planes, the fascial planes between the muscles, and rapidly spread.
Right.
You'll often get air in there, crepitus. You push and you can actually feel the air. You may also get deeper staph infections. There's a syndrome, tropical pyomyositis, where the staph, rather than just being in the skin, will get deep down into the muscles, and it is dramatic, the amount of pus that can come out. So when we make our cellulitis diagnosis, we're also making a distinction that this is not necrotizing fasciitis, that this is not pyomyositis.
Right. So how do you do that?
Well, so part of it is visual, as we discussed. You're going to be looking at the cellulitis, and does it look like it's superficial? Is there tension in the area, or is it really just the surface of the skin? In your purulent cellulitis, you're going to be looking and feeling for areas of fluctuance, areas where it feels like an abscess either has formed or is forming.
Is that painful?
It's often painful, and often with purulent cellulitis, people will give you the history of, well, doc, I was sitting there and all of a sudden I got bit by, it's always a spider. I got bit by a spider.
Right.
And it hurts, and they look down and they see this red area, And then that is where the infection started. And why does it hurt? Right? Why would a little microscopic bacteria suddenly give you this pain that feels like a bite?
Edema. It sounds like there's edema associated with this.
So it's exactly, it's the stretching. So the now we're going to go back to your childhood. I think it's your childhood.
Again.
And we're going to talk about purulent cellulitis. We're going to talk about furuncles and carbuncles.
Furuncles.
Do you remember those? Have you heard of?
Oh, I've had carbuncles. Oh, yes, I have. Carbuncles.
So let's talk about, this is terminology that may be old, but I think it's still relevant.
Oh, yes.
Is Staph aureus, I want to say likes to, but maybe I shouldn't personify a bacteria.
Has a penchant for.
Has a penchant for. It tends to invade down into hair follicles, and at the base of a hair follicle is a single layer of cells where the bacteria can penetrate.
Right.
So it's a point of vulnerability.
Yep.
And the bacteria will start to multiply in the hair follicle, will start to distend, and that actually is this sharp pain where you feel like, ow.
Yeah.
So a single infected hair follicle is a furuncle. When multiple get infected and they coalesce, then that becomes a carbuncle or abscess.
Right.
And so people will often show you, I have a rash, but you'll see there's a focus to the rash.
Right.
And that focus is a furuncle or carbuncle.
Yep.
And the treatment, we'll get into treatment here for the purulent cellulitis, is going to be draining that. Back to the days of the barber.
Good Lord.
The one person in town who actually owned a knife and could drain the carbuncles and furuncles.
This is true. So I was at camp once. This was a biological station up in Michigan, in the Upper Peninsula of Michigan. Okay. Actually, it was the Lower Peninsula of Michigan, but it was almost in the Upper Peninsula. Okay.
So we're in the United States. We're in the Great Lakes region.
We are. The University of Michigan ran this. They still do. It's near Pellston, Michigan, and I don't know how this happened, of course, but and most people don't remember the incident. I don't blame a spider on this one. But I developed a carbuncle, according to the local doc, who was the doc on call for this biology camp. It was a fantastic place to go learning. But I remember the treatment. The treatment was rather direct and not predictable. He said, well, we're going to treat this as follows. And he got out a cloth with an ice cube in it. He put it on my carbuncle, and the pain went away because of extreme cold. Probably reduces the swelling a little bit. It also reduces the pain. Then he took out a pair of bandage scissors, and he held them over an alcohol flame. And he says, this might hurt a little bit. I didn't want to look even, and he jammed it down into the carbuncle and spread the scissors apart to aerate this carbuncle. I nearly jumped out of the table. And he says, this is the best thing I can do right now. We don't have the medical facilities of a hospital, and we get a lot of this. And I never wanted to get another one after that. I was ultra careful about avoiding abrasions and that sort of thing. And I'm not sure he did the right thing, but it certainly helped eventually. And aerated, it drained.
Yeah.
Induration went away. Pain went away. That was as good as new. Without a scar, by the way, I must say.
Yeah. Well, let's talk about the treatment is going to follow from an accurate diagnosis.
Okay.
And so the accurate diagnosis that you want to make is non-purulent or streptococcal cellulitis, or erysipelas.
Sure.
That is going to respond very quickly to antibiotics that target strep.
Yep.
So we often recommend amoxicillin.
Yes. Which
still to this day, and I think it's another little pearl, streptococci species, so streptococcus, does not produce beta-lactamases. You do not need the clavulanic acid, the beta-lactamase inhibitors, the sulbactam. You can just use pure amoxicillin. The only thing those other things are going to do is upset your stomach and limit your dosing.
Right.
And that's a feature of the bacteria. It just can't become resistant. So to this day, all streptococcal species are sensitive to our penicillins.
Nice.
So not only could you use normal penicillin, but amoxicillin has better bioavailability, as in when you take a pill, you get higher levels. So you can treat children all the way through adults with amoxicillin. And you also can use some of our cephalosporins.
Right.
And that is the ideal treatment for non-purulent cellulitis. No need to use any of these newer, fancier, more expensive drugs, and there's no reason to pull out the scissors or the scalpel.
None.
But now let's move into purulent cellulitis.
Different story.
Different story. And with purulent cellulitis, you are worried about staph.
Yeah.
It's not the only one that can cause purulent, but it is most common. And the incision and drainage, the IND, like you described, is actually, that's the treatment. That alone is curative. And it's not actually clear that additional antibiotics adds much. And so I'll just discuss this a little because I know there's some controversy here. Some people will say, oh, let's give a day of antibiotics and then we'll feel like it's a little safer to do the incision and drainage. What you're really doing is you're allowing the infection to progress. You're allowing this pocket of infection to go unchecked.
Exactly.
So I'm going to advise against waiting. Someone who's competent, and this takes a certain level of competency and skill, because you start trying to do incision and drainage, there's nerves, there's arteries, there's other structures. You want to be careful that you know what you're doing. But if you know what you're doing and you're able to open up one of these pockets of infection, that can be curative. People will add additional antibiotics if there tends to be a cellulitis around it, or it has been shown to reduce the incidence of recurrences. But when you're doing this, now you want to start thinking about anti-staphylococcal penicillins or anti-staphylococcal antibiotics if you're going to be treating with antibiotics.
Right.
So one is, I'm going to say, with limited resources, judgment call. Do we even need antibiotics? What we do need is incision and drainage. If there's an abscess, a pocket of pus, our antibiotics can't get in there. They're not going to make a difference. But if we are able to open this up, sometimes we have the opportunity, should the resources be there, to determine, is this a resistant staph, where we have to use things like sulfa trimethoprim? Is it a sensitive staph, for instance, where we can actually go ahead and use our cephalosporins?
Right. So do you ask the question, have you ever had this before, to determine whether or not it's a treatable disease, or whether or not they've already had this treated and it didn't go away? So now you really have to ask, what were they treated with? And you have to switch antibiotics.
Yeah, it's interesting because most of the staph time, when you would be worried about resistance, it's going to be the incision and drainage.
Okay.
So again, it's going to be a question, has this been adequately drained?
Yeah.
People will often come in and say, oh, I just keep getting these. And then you think about the fact that maybe the staph or the strep living on their body is, for them, more pathogenic than other, and we'll often even do what we call decolonization protocols, where we'll try to basically clean off the flora that they have now and I guess it would be fauna, right?
Yeah.
It would be fauna.
Your external microbiome. So throw a monkey wrench in all of this and tell me something about acne.
Okay. So acne is a different bacteria. So it's going to be often a Propionibacter acnes. So it's going to respond to different treatments. Usually what you're doing is you're trying to disturb the environment. Okay. So our benzoyl peroxide, things that might dry out so that it's a less hospitable environment for the bacteria.
Okay.
But along the same lines, cellulitis tends to be most common in the summer. We have our big spikes in the moist, humid time of the year. So in certain areas where it's always moist and humid, there may be no real seasonality to it. But if you can keep these areas clean and dry, prevent skin breaks, you can reduce the risk.
Sure. So I'm thinking that people who take camping trips in the summer and are not used to being outdoors and are bitten by a lot of arthropods, which cause you to itch, and then you itch so much that you're actually infecting the wound, and that can lead to a carbuncle, and that can lead to a more serious condition for some people.
Yeah.
Right?
So a lot of our skin infections will be secondary to some sort of trauma, some sort of bug bite, the human desire to scratch, and now you've broken that protective barrier.
Exactly.
and you've got entry for the
Exactly.
different bacteria.
So we know some spiders that can cause some horrible skin conditions.
We do.
We do. And nothing of what you just said describes a spider bite by the recluse spider, which is the most common cause of this very serious manifestation. So those are rare events, basically. You often look for those two little holes also that the chelicera make from the spider itself. You don't see too little of those, you're suspicious it might not be a spider bite.
Yeah, I agree with you. The poor spiders are just
And
blamed
they're
for so
they
much.
are. And they do so much good.
So I think those are our pearls. Is you want to
Okay.
make a distinction: is it cellulitis versus a
Right.
deeper infection?
Right?
Cellulitis non-purulent versus cellulitis purulent.
Yep.
Non-purulent, you're going to worry about strep. Purulent, you're going to worry about staph, potentially resistant, and you're going to be thinking about calling someone who has surgical expertise who can do your incision and drainage.
Great.
All right. Well, thank you for joining us again.
See you next time.